The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/VKE860. Downloadable slides and practice aids are also available.
Hello, and welcome to Advances in AML Care, Highlights from Recent Science. I'm Dr. Harry Erba, Director of the Leukemia Program at the Duke University Medical Center. During this presentation, we'll assess some of the evidence that has recently made a difference in how we manage many different, diverse AML patient populations, and also discuss some recent updates from the virtual annual ASCO conference. Let's begin by looking at how the overall shape of AML management has changed. Traditionally, we have considered therapy for patients fit or unfit for intensive chemotherapy. Of course, there is no clear definition of how to distinguish these populations. However, once done, patients who have been considered fit for chemotherapy receive an induction chemotherapy with 7 days of cytarabine and 3 days of an anthracycline, typically daunorubicin or idarubicin. For the patients who achieve a complete remission, we then consider post-remission strategies based on their history and results of cytogenetic data. Those with favorable risk core binding factor leukemias are continued on high-dose cytarabine consolidation chemotherapy alone. Those with unfavorable risk karyotypes, complex karyotypes deletion 5, monosomy 7, are allocated to allogeneic hematopoietic stem cell transplant if appropriate. And then approximately 50% of patients were considered intermediate risk. And there was often discussion between the physician and the patient regarding chemotherapy consolidation versus allogeneic stem cell transplantation. In more recent years, we have used mutational profile and even MRD assessments to help educate us and illustrate how patients may be best served by chemotherapy versus allogeneic stem cell transplant. On the other hand, those unfit for intensive chemotherapy were often considered for clinical trials. Outside of clinical trials, the decision was between hypomethylating agents, best supportive care, and hospice care. Quite a diversity in therapeutic approaches, possibly due to the fact that the response rates with hypomethylating agents are approximately only 20 to 25% complete remission rate. However, over the last 2 to 3 years, there have been several approvals and the emergence of novel agents for patients with AML. Leading the way back in April of 2017 was midostaurin for newly diagnosed AML patients with FLT3 mutation in combination with intensive chemotherapy. And more recently, the second generation type 1 FLT3 inhibitor, gilteritinib, for relapse-refractory FLT3 mutated AML. Other targeted agents have included ivosidenib and enasidenib for IDH1 and IDH2 mutated AML, respectively. Gemtuzumab ozogamicin was reapproved by the FDA with a rather broad labeled indication in both previously untreated and the relapse-refractory patient population for those with CD33 positive AML. In terms of chemotherapy approaches, for secondary AML and AML that is therapy-related, CPX-351, a liposomal encapsulation of daunorubicin and cytarabine, was approved. And probably, in my opinion, one of the greatest advances for the majority of our patients with AML has been the approval of combinations for older, unfit AML patients, venetoclax with the hypomethylating agents or with low-dose cytarabine, and the hedgehog inhibitor glastigib with low-dose cytarabine. We will not be discussing today the approval of the anti-CD123 targeted therapy for blastic plasmacytoid dendritic cell neoplasm. So let's start by discussing older AML patients who are felt to be fit for intensive chemotherapy. And there is a novel cytotoxic approach in this patient population, and that is CPX-351, or a liposomal formulation of cytarabine and daunorubicin. This liposomal formulation has a synergistic combination of cytarabine to daunorubicin in a fixed 5:1 molar ratio. It is encapsulated in 100 nanomolar bilamellar liposomes. It has been shown that these liposomes preferentially target the bone marrow and are preferentially taken up by leukemic compared to normal blasts. It's also been shown that this drug ratio is maintained for greater than 24 hours and persists for at least 7 days. Based on the results of a phase 3 study that we are about to review, this was approved in 2017 for the treatment of adults with newly diagnosed therapy-related AML or AML with myelodysplasia-related changes. The phase 3 study accrued over 300 patients with AML that was either therapy-related or following a history of myelodysplastic syndrome or chronic myelomonocytic leukemia, and finally those with de novo AMLs with an MDS-type karyotype. Patients needed to be between the ages of 60 and 75 and able to tolerate intensive chemotherapy with adequate performance status. These patients were randomized to receive 3 doses of CPX-351 on days 1, 3, and 5, or standard 7+3 with daunorubicin at 60 milligrams per meter squared. Those patients achieving a remission would go on to receive CPX-351 for 2 days or a 5-2 consolidation for up to 2 cycles. And of course, patients in this high-risk group who were deemed fit and eligible for intensive chemotherapy followed by allogeneic stem cell transplant would be able to undergo allogeneic transplant. The phase 3 study met its primary endpoint with an improvement in the median survival of patients treated with CPX-351 to 9.5 months compared to approximately 6 months with 7+3 chemotherapy. Furthermore, in patients who were able to undergo allogeneic stem cell transplant following treatment with CPX-351, their overall survival was much superior to that of patients who had received 7 and 3 and then proceeded to allogeneic stem cell transplant. The overall remission rate was also significantly higher with CPX-351 versus 7+3, 48% versus 33%. Now, at this year's ASCO meeting, we saw the results of the planned 5-year follow-up of this phase 3 study. The median survival, again, 9.3 months versus 6 months in favor of CPX-351. Furthermore, the 3-year Kaplan-Meier estimated survival rate was double in the CPX-351 arm compared to 7 and 3, 21% versus 9%, and at 5 years the same, 18% versus 8% with 7+3. The benefit of CPX-351 seems to be most apparent in those patients who receive CPX-351 and then proceed to allogeneic stem cell transplantation. Here you can see the 3-year Kaplan-Meier estimated survival rate of 56% versus 23% in those who received 7+3. The approval of CPX-351 was based on clinical data such as prior therapy and patients with a history of MDS or CMML and on cytogenetic data. However, we also now have data regarding the mutational profile of these patients. 60% of patients had samples available at the time of initial diagnosis and being put on this study for molecular analysis. When we looked at the outcomes of these patients who had samples submitted and those who did not, they were very similar. And what we saw was this was a very high-risk group of patients based on the mutational profile. 1/3 had p53 mutated AML. Many of these were therapy-related AML or AML following or AML with a complex karyotype. The largest group of patients were those with secondary type AML. These are patients who have mutations in the spliceosome genes as well as chromatin modifiers. There was no apparent benefit, however, of CPX-351 compared to 7 and 3 for patients with p53 mutated AML. The response rates were quite similar, and you could see that the overall survival and median survival were nearly identical. The benefit appeared to be in patients who did not have p53 mutated disease. And if we look at a little bit more detail, On the left, you could see the outcomes of patients with secondary type acute myeloid leukemia. Clinically, these are typically patients who had a history of MDS or may have had MDS and have progressed to AML. And here you could see the benefit of CPX351 over 7+3. And again, for the other patients with activating signal mutations, there was no apparent benefit. It's important to recognize that many of the patients in this clinical trial received CPX351 in the hospital for induction therapy. However, approximately half of these patients underwent outpatient administration of CPX351. In this subgroup of patients who received consolidation, the median overall survival was prolonged among patients receiving CPX351 versus 7+3 followed by 5+2, with a median survival of 25 months with CPX351 versus 8.5 months in those receiving 7+3 followed by 5+2. And the safety profile of CPX351 during consolidation was consistent with earlier reports. There was less early mortality with CPX351 versus 7 and 3 as well. Here you can see the 30-day mortality was approximately 6% with CPX351 versus 10% with 7+3. However, it should be noted that there was similar incidence of febrile neutropenia, pneumonia, bacteremias, sepsis, respiratory failure in both the 7+3 and the CPX351 treatment arms, suggesting that it was the control of the AML that was more important in leading to the lower early mortality. However, it must be recognized that there was delayed count recovery with CPX351, 6 days longer prolonged recovery from neutropenia and thrombocytopenia versus 7+3. And so whether you choose to treat the patient as an inpatient or an outpatient during induction, it is critical that these patients be monitored very closely with lab assessments at least 3 times a week during the outpatient time for potential transfusion support, and frequent transfusions may be needed. Let's now turn to the data supporting the use of venetoclax in combination with the hypomethylating agents and low-dose cytarabine. BCL2 inhibits apoptosis in both normal and malignant cells and is typically overexpressed in AML. Early BCL2 inhibitors such as navitoclax also inhibited BCL-XL, which contributed to the toxicity, mainly thrombocytopenia. The BCL2 inhibitor venetoclax is an orally bioavailable agent that is a BH3 mimetic without activity against BCL-XL. In a phase 1b followed by phase 2 expansion, venetoclax was evaluated in combination with hypomethylating agents. The physicians were allowed to choose between azacitidine 75 milligrams per meter squared for 7 days or decitabine 20 milligrams per meter squared IV days 1 through 5. The dose of the venetoclax was ramped up in the first several days from 100 milligrams to the final target dose as high as 1,200 milligrams in the phase 1b part of the study. There were 145 patients total treated in the phase 1 study. Let's focus now on the patients who received the currently FDA labeled dose of 400 milligrams of venetoclax in combination with hypomethylating agents. 73% of these patients achieved a CR or a CRI with a median duration of response of 12.5 months. And the median overall survival in this group had not been reached at the time of this report. Regardless of age, less than 75 or 75 or older, over 2/3 of patients achieved a response, 69 and 65% respectively. And again, the median duration was 12.9 months in the younger patients and 9.2 months in those over the age of 75. Furthermore, whether the patient had de novo AML or secondary type AML, 2/3 of patients responded. In the entire phase 1b study of 145 patients with a median age of 73, you can see that the median overall survival was 17.5 months, and at 1 year, the estimated survival was 60%. At the annual ASH meeting in Orlando, Florida, Dr. Chila presented data on the outcomes by mutational subgroups. Patients with nucleophosmin mutation and those with IDH1 or IDH2 mutations had the highest response rates, CR/CRI rates of 74 to 93% in this group of patients. However, even in patients with P53 mutation, 57% of patients achieved a CR or CRI. Patients with FLT3 mutation, close to 50% achieving remission. However, it should be noted that again, with this combination of hypomethylating agent and venetoclax, the long-term outcome and survival of patients with TP53 mutated disease is quite poor, with a median survival in this group of 6.4 months. Of over 300 patients treated with hypomethylating agents or low-dose cytarabine in combination with venetoclax, approximately 10% or 31 patients underwent allogeneic stem cell transplantation. Most of these patients, all but 3, underwent the transplant in either a CR, CRh, CRI, or morphologic leukemia-free state. Keith Pratt presented at the ASH meeting in 2019 that the 12-month overall survival rate was 84% in these patients who were highly selected and able to undergo allogeneic stem cell transplant. And it should be noted that when these patients were treated on the initial phase 1b studies, that they were not felt to be eligible for intensive chemotherapy and stem cell transplant by their physicians. Unfortunately, older patients treated with intensive chemotherapy still have an unacceptably high risk of relapse. At the 2019 ASH meeting, Andrew Way presented the results of the phase 3 study of CC486 as a potential maintenance strategy. QUASAR was a phase 3 study evaluating CC486, also known as oral azacitidine, versus placebo for older patients over the age of 65 who had intermediate or poor risk cytogenetics and AML in first remission following intensive induction chemotherapy. And in fact, 80% of these patients also received consolidation chemotherapy. Now, there have been prior attempts to look at and evaluate hypomethylating agents as a potential maintenance strategy. One of the more recent studies performed in Europe compared azacitidine given parenterally for 12 months versus best supportive care and observation for patients who were older and in first remission after induction. None of these patients had received consolidation. There was an improvement in relapse-free survival, but not in overall survival. In this study, patients who had failed, received induction and most of them consolidation were randomized 1-to-1 to oral CC486, 300 milligrams daily for 14 days in a 28-day cycle, or placebo. And this was continued as a maintenance. If during therapy there was evidence of relapse with the marrow blast percentage increasing to 5 to 15%, dose escalation of CC486 or placebo to a 21-day schedule was allowed. At the time of relapse, with over 16% bone marrow blast, therapy was discontinued. The primary endpoint was overall survival, and the QUASAR study met its primary endpoint of improvement in overall survival. The median survival with CC486 was nearly 25 months compared to 15 months in patients who were randomly assigned to receive placebo. The 1-year relapse rate was 53% in the CC486 arm and 71% in the placebo arm. However, please note that by 4 years, both survival curves are quite similar, with only 20% of patients still alive. There have been several recent updates from the ASCO, virtual ASCO meeting in 2020 regarding the QUASAR study. First of all, CC486 was generally well tolerated in all age groups, including elderly patients age 75 and older. The quality of life and fatigue, low levels of fatigue, were preserved in patients receiving CC486 maintenance therapy, which is very important in older patients agreeing to undergo indefinite maintenance therapy. Another observation from the QUASAR trial that Andrew Wade presented in 2019 was that the benefit of CC486 was seen in both patients who were positive for measurable residual disease or negative. And finally, at the ASCO 2020 Congress, in patients experiencing first relapse, so between 5 and 15% blasts, escalation of the CC486 to 21 days was well tolerated and resulted in prolongation of overall survival and restoration of remission in approximately a quarter of patients. And so it's recommended that we consider the 21-day dosing schedule for patients who are experiencing relapse. So what do I take away from these new recent updates? Well, first of all, it is clear that CPX-351 is superior to 7+3 in the population study, older patients with high-risk AML defined as therapy-related or AML with myelodysplasia-related changes, patients who had a prior history of MDS, CMML, or have myelodysplasia-related cytogenetic changes in a de novo AML. And in fact, in this age group, 60 to 75, no other regimen has been shown to be superior to 7 and 3 until CPX-351. However, still, there's no apparent benefit in the TP53 mutated group of patients, and this remains an unmet need. However, there is apparent benefit in those with secondary AML genotype, those with spliceosome and chromatin modifier mutations. Therefore, CPX-351 should be strongly considered in those patients who will be felt to be eligible for allogeneic stem cell transplantation in first remission. Now, on the other hand, remembering that AML is a disease of the elderly with a median age of 68 to 70, the venetoclax-based regimens have now become a new standard of care for patients age 75 and older and those with significant comorbidities. And although in fact, all of these patients on the study were not felt to be eligible for allogeneic stem cell transplant, they appeared to become eligible with effective therapy and were able to undergo allogeneic stem cell transplant with a 12-month survival of over 80%. And finally, CC486, also known as oral azacitidine, is likely to become a new standard of care in AML. We have not used maintenance therapy in AML patients in first remission despite decades of clinical investigation looking for an agent that can prevent relapse. CC486 is the first agent that has been used during maintenance therapy for patients in first remission following intensive chemotherapy to show an improvement in survival and a decrease in the risk of relapse. However, it must be considered that if the patient was fit for intensive chemotherapy and remains eligible for allogeneic stem cell transplant, that allogeneic stem cell transplant appears to be preferred based on higher expected long-term survival. The majority of patients with acute myeloid leukemia are over the age of 65 at presentation. These older adults often have significant comorbidities that may make them unfit for intensive chemotherapy. We have used the hypomethylating agents alone in this group of patients in an attempt to achieve remissions and hematologic improvements. However, the complete remission rate is only 20 to 25% with both azacitidine and decitabine. And therefore, it shouldn't be unexpected, given these low response rates with hypomethylating agents, that many older patients actually choose not to undergo therapy for their acute myeloid leukemia in the past. In fact, in an analysis of SARE registry data linked to Medicare claims, only about 35 to 40% of Americans 65 years or older received any form of intravenous chemotherapy for AML in the past decade. However, I believe this is about to change. In November of 2018, the US Food and Drug Administration approved venetoclax in combination with low-dose cytarabine, venetoclax in combination with the hypomethylating agents for patients with AML previously untreated, ages 75 or older, or those with significant comorbidities that preclude the use of intensive chemotherapy. Following these approvals, phase 3 studies had been planned and were in progress. The VialeA Trial was a phase 3 study comparing low-dose cytarabine with venetoclax to low-dose cytarabine with placebo. This was an international trial of 211 patients with either secondary or de novo previously untreated AML. Patients were stratified based on age, those 75 and older or versus younger, and by region of the world in which they were treated. They were randomized 2-to-1 to low-dose cytarabine given 20 milligrams per meter squared daily, days 1 through 10, with venetoclax ramped up to 600 milligrams over the first 4 days, versus low-dose cytarabine with placebo. The patients could continue receiving treatment until progression or until study treatment discontinuation criteria were met. Patients remained on study for overall survival assessments and follow-up, even if they initiated additional lines of therapy. The AliC data has now been presented at the annual ASCO meeting in 2020. And although there appeared to be a trend for improvement in survival with the addition of venetoclax with low-dose cytarabine, the median survival was not statistically improved with that combination versus low-dose cytarabine with placebo, 8.4 months versus 4.1 months. There was a modest increase in hematologic adverse events in the venetoclax arm, but in general, the venetoclax and low-dose cytarabine arm was well tolerated and associated with manageable toxicities. The rates of adverse events leading to treatment discontinuation were similar in the two arms, 24 versus 25%, and the rate of serious adverse events such as pneumonia or sepsis were nearly identical between the two arms. On the other hand, the VialeA trial compared azacitidine and venetoclax to azacitidine placebo and met the primary endpoint of improvement in survival. Among treatment-naive, predominantly elderly patients with AML ineligible for intensive chemotherapy, azacitidine with venetoclax led to a statistically significant and clinically meaningful improvement in response rates and overall survival compared with azacitidine and placebo. There were serious adverse events as expected, such as febrile neutropenia in 30% of patients and pneumonia in 16% of patients treated with the combination. But the rate of laboratory tumor lysis syndrome was actually quite rare, only 1%. In looking at these Kaplan-Meier curves, not only was the median survival improved from almost 10 months with azacitidine alone to almost 15 months with azacitidine with venetoclax, but also at 12 months and at 24 months, more patients were alive. In other words, unlike the AML-001 study comparing azacitidine to conventional care regimens in a similar group of patients, the survival curves did not come together, at least at this point in the analysis. Based on the phase 1b, phase 2, and now phase 3 trials of venetoclax in combination with the hypomethylating agents, I believe we truly have a new option for older patients unfit for intensive chemotherapy. This is our new standard of care, and all future regimens that are being investigated in this group of patients need to consider azacitidine, hypomethylating agents, or low-dose cytarabine with venetoclax as the control arm and the comparator. However, there are some things that we need to consider from this data set. First, patients receiving prior hypomethylating agents for myelodysplastic syndrome were excluded. And so we aren't certain of the benefit of the addition of venetoclax to a hypomethylating agent in a patient who has been on a hypomethylating agent and has progressed to myelodysplastic and who's progressed to AML. There's no data or no significant data in patients with prior myeloproliferative neoplasms or MDS and MPN overlap syndromes. The prognosis of TP53 mutated AML remains poor, even with these combinations of venetoclax. Responses of approximately 50% can be seen, but again, duration of response and overall survival is low. There are a number of caveats as well. In this clinical trial, the patients needed to have a white blood cell count less than 25,000. Now, hydroxyurea could be used for cytoreduction, but it is very important to achieve cytoreduction prior to the first cycle, given the risk of tumor lysis syndrome with the combination of HMA and venetoclax. We also need to continue to learn how to manage the myelosuppression that is seen with the combination of HMA with venetoclax. It should be noted that in the clinical trial, patients would have a bone marrow biopsy between days 21 and 28. And if there was a morphologic leukemia-free state or marrow aplasia, the treatment with venetoclax was held at that point to allow blood count recovery. This is going to be important for managing older patients who have pancytopenia following this induction regimen. And then finally, drug-drug interactions need to be considered when using venetoclax and in combinations. We now have therapies available for our patients with AML that are directed to some of the more common mutations that are seen in this disease. 2 trials have investigated the use of second-generation FLT3 inhibitors for patients with relapse refractory acute myeloid leukemia, and both of these clinical trials met the primary endpoint of improvement in overall survival compared to chemotherapy. The second-generation drug quizartinib improved overall survival versus salvage chemotherapy in this group, and so did gilteritinib compared to salvage chemotherapy in the ADMIRAL trial. Gilteritinib is now FDA approved for FLT3 mutated AML that is either relapsed or refractory following prior therapy. Now, of course, the first generation type 1 inhibitor midostaurin had already been approved in combination with 7+3 and high-dose cytarabine consolidation for patients with FLT3 mutated AML based on the results of the RATIFY trial. On the other hand, ivosidenib and enasidenib have been approved on the basis of phase 1 and phase 2 expansion studies in patients with IDH mutated AML that is relapsed or refractory. IDH1 mutations occur in approximately 5 to 10% of AML patients, IDH2 mutations in approximately 10 to 15% of patients. Both of these agents will induce complete remission rates of approximately 20 to 25% with median survivals of 9 months. Let's look at the data from the ADMIRAL trial showing the benefit of gilteritinib over salvage chemotherapy. We have known for many years that intensive chemotherapy in patients with relapsed AML with FLT3 mutation has a very low chance of achieving remission. Only 25% in a prior phase 3 study of lustortinib versus chemotherapy. In this clinical trial of salvage chemotherapy, most patients receiving MEC or IDA flag, the complete remission rate was only 13% with salvage chemotherapy, and it was only 11% with salvage chemotherapy and 21% with gilteritinib. If you include CRI and CRP, again, there was a doubling of the remission rate with gilteritinib, 54% versus 22%, and CRH, 34% versus 15%. There was an improvement in median survival with gilteritinib, 9 months versus 5.5 months with salvage chemotherapy. But it should be noted again that these survival curves do come together again after 21 months, indicating that single agent FLT3 inhibitor will not be the final answer for a patient with relapse refractory AML. In fact, many of these patients should be considered for allogeneic transplantation. And in fact, in the AML trial, patients were able to undergo or start receiving gilteritinib again following allogeneic transplant. Now, this was not a random assignment. It was at the patient and physician discretion. And of course, there may have been a clear selection bias. However, those patients who resumed gilteritinib did have an improvement in overall survival compared to those who were not able to continue gilteritinib. Let's look now at some updates of the IDH1 and IDH2 inhibitors. They've been approved in relapse refractory disease initially, but they have also been tested now in newly diagnosed patients. There was an initial phase 1b study evaluating azacitidine with either ivosidenib or enasidenib, both at their labeled doses, showing tolerability of the combination. Enasidenib with azacitidine then was compared to azacitidine alone in a randomized phase 2 study with a 2-to-1 randomization. In these IDH2 mutated AML patients with newly diagnosed AML, the combination of enasidenib with azacitidine led to a much higher response rate, 71% versus 42% with azacitidine alone. This benefit was seen in terms of CR or other forms of response. The time to first response, again, it should be remembered, was approximately 2 months, but the duration of response was 24 months. What is not shown in the slide, but very interesting, is that the overall survival of the patients in these two arms was nearly identical and over 21 months in both arms, suggesting that patients who are treated with azacitidine alone and do not respond or progress could then go on to receive enasidenib alone or in combination. However, the response rates and getting a patient into remission quickly is important, and this combination clearly did so. In terms of the safety analysis, the enasidenib and azacitidine were generally well tolerated with a safety profile similar to the monotherapy experience. Again, it should be noted that differentiation syndrome has been associated with both ivosidenib and enasidenib, and in this trial occurred in 10% of patients treated with the combination with enasidenib. Ivosidenib has been evaluated in newly diagnosed, previously untreated IDH1 mutated AML patients. The median age of this group was 76 years, and ivosidenib was associated with an overall survival, median overall survival of just over 12 months, with 42% of patients achieving CR or CRh. And in fact, mutational clearance was seen in 64% of the patients with CR, CRh, suggesting that ivosidenib may actually alter the biology of mutated IDH1 AML. Ivosidenib has also been evaluated with azacitidine with an overall response rate of 80% in that group of patients. So in summary, we now have agents that are directed to components of the mutational landscape of AML. The addition of midostaurin to standard chemotherapy has improved the survival of FLT3 mutated AML patients, but it should be remembered that these patients should undergo allogeneic stem cell transplant in first remission, given the continued risk of relapse, even with midostaurin-containing regimens. Gilteritinib, a single agent, orally bioavailable, has been shown to be superior to chemotherapy in relapse refractory FLT3 mutated AML. And it leads to the question whether these second generation FLT3 inhibitors, such as quizartinib, gilteritinib, and crenolanib, may improve outcomes when added to standard chemotherapy induction and consolidation. And those trials are in progress. Furthermore, although the FLT3 inhibitors quizartinib and gilteritinib both led to higher response rates in FLT3 mutated AML patients compared to salvage chemotherapy, the response rates remain low. And so can outcomes be improved by combining these FLT3 inhibitors with chemotherapy or low intensity therapies? And again, those trials are in progress. And finally, the use of the FLT3 inhibitors is being evaluated in the maintenance setting post-allogeneic stem cell transplant. IDH mutated AML um, occurs in about 20% of the AML population. The overall response rate is only approximately 25 to 30% with single agents. However, combinations with hypomethylating agents may increase those responses. It should be noted that patients who have mutations in the receptor kinase pathway, such as FLT3, have a lower risk or lower rate of response. These agents work by allowing differentiation of the leukemic blasts and thereby leads to one of the more notable serious adverse events that can occur with ivosidenib and enasidenib, and that is the differentiation syndrome. The syndrome must be recognized quickly and treated with dexamethasone, often associated with leukocytosis, so hydroxyurea may be needed as well. However, the addition of these oral IDH inhibitors gives us yet another tool for treating patients with acute myeloid leukemia, especially those older who cannot tolerate intensive chemotherapy. In summary, what we've seen today is that the additional clinical experience with several novel therapeutics has confirmed their role as now standard management options in different AML populations. From older patients who are fit for intensive therapy, including those with high-risk disease, older patients who are unfit for intensive therapy, and those who present with mutation-defined disease. Thank you for joining me. I hope you found this program useful for your practice.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/VKE860. This activity is supported through educational grants from Bristol Myers Squibb and Jazz Pharmaceuticals Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.